Good evening, everyone. I am Ashish, Vice President with Zydus, and at the outset, I thank Mumbai Hematology Group for giving Zydus this opportunity to collaborate for today's webinar on high-risk myeloma management. With COVID continue to keep coming back in waves, but it also has brought a wave of digitalization and opened an opportunity to have the experts from across the globe to connect with as many clinicians as possible, which is further helping improve the clinical outcomes across the globe. And today I welcome our eminent guest speaker, Dr. Maury A. Gertz, who has joined us from Minnesota, USA, from Mayo Clinic. Very good morning, sir. A very warm welcome to our eminent faculty members who will be discussing key issues in management on high-risk myeloma with Dr. Maury post his session. I also welcome virtual delegates who have joined us for today's webinar from not just India, but across the globe. Now a special welcome to the person who has got everyone together for today's webinar and made the biggest use of digital platform by initiating this virtual hematology university, where we have experts every week since last 2 years to share the knowledge with everyone who is keen to learn. Professor Dr. M.B. Agarwal. Sir will also moderate today's session, and I have the privilege today to introduce Professor Dr. M.B. Agarwal. He is presently the head of Department of Hematology at the Bombay Hospital Institute of Medical Sciences at Mumbai, and also the Director of Hematology Center located at Dadar. He also acts as a consultant hematologist at a number of hospitals in Mumbai, including the Lilavati Hospital in Breach Candy. Sir has held a number of important positions, some of which are past President, Indian Society of Hematology and Transfusion Medicine, President, Mumbai Hematology Group Selection Committee at Department of Pathology at Tata Memorial Hospital, Mumbai. Sir's careers, we can talk as much as possible, has been spanned over 4 decades, which has not just helped patients in India get better, but has also inspired so many young clinicians to take up hematology. And Sir has always taken the lead to disseminate hematology updates by bringing the eminent and expert group together like today. Thank you, sir, for all your efforts. And with that, I'll request you to take the session forward from here. Over to you, sir.
Thank you, Ashish, for your kind words. So, good evening, friends. Today's lecture is on high-risk myeloma management, and our guest speaker is well-known personality. All of you know him very well, Dr. Maury Gertz from Mayo Clinic, USA. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, managed by Mice Ideas. Tomorrow morning, we have a webinar by Professor Soumya Nityanand on allogenic transplant in aplastic anemia at 11:30 a.m. Our discussants today include a number of very important personalities from India. We have Dr. Ritu Gupta, professor from All India Institute, Delhi. Dr. Priyanka Srivastava, associate professor, Pramukh Swami Medical College, Karamsad Anand. Dr. Isha Kaul, associate director, Max, New Delhi. Dr. Eva Bhagat, hematologist, Cure Center from Ahmedabad. Dr. Alka Khandwal, additional professor, PGI Chandigarh. Dr. Shilpa Prabhu, consultant at Majumdar Shah Medical Center, Bangalore. Dr. KK Radhika from Nizams, Hyderabad. Dr. Nidhi Jain from Zydus, Ahmedabad. And Dr. Aditi Tanki from Sterling Cancer Hospital, Rajkot. I thank Mr. Ashish Kumar and the team from Zydus Oncology for supporting our academic activities. Mr. Rajesh Kalpesh and their team from Mice Ideas for managing these shows flawlessly, the Executive Committee of Mumbai Hematology Group, and of course, our guest speaker, Dr. Mori Gertz from Mayo Clinic. All you discussants who are themselves eminent hematologists and medical oncologists, and all the participants, as was mentioned, from almost 14 to 15 countries near India and even from outside Asia. We get all of you because we have such grand personality speaking to us. A few words about Dr. Mori Gertz. As you know, he is Professor, Division of Hematology, Department of Internal Medicine at Mayo Clinic, Rochester. He's member, Committee on Training, American Society of Hematology from 2015 onwards. Member of Hematology Board Exam Committee, American Board of Internal Medicine, 2015 onwards. Waldenstrom Award for Medical and Scientific Achievements in Waldenstrom's macroglobulinemia, way back in 2014. Treasurer, International Myeloma Society from 2011 to 14. Mayo Clinic, Roland Sedler, Junior Professor of the Art of Medicine, honoring Dr. Michael Brenner, 2010. President, Mayo Staff Officers and Counselors, Mayo Clinic, 2005. We are privileged. He has been virtually our friend. He was personally here, I remember, for the launch of Velcade almost 2 decades ago. And then he has been helping in educating our colleagues and students, not only from India, but from this part of the world repeatedly by lecturing us. Today, he's going to speak on high-risk myeloma and its management. Over to you, sir.
Thank you, Professor Agarwal and Mr. Kumar, for your support. I'm most grateful and I'm delighted to be here with you today. And so we'll start by, is this correct? Nope, that's not correct. Excuse me, I'm sharing the wrong screen. Try again. Okay, let's just take a look and see where we are. Whiteboard. My apologies. I don't know. Here we go. Thank you very much. We'll do this and we'll do this. And now we should be ready. So high-risk multiple myeloma really is an unmet need for our patients with multiple myeloma, and it still is a major deficiency in our ability to effectively manage this disorder. And unfortunately, even with my talk, I don't think we really will achieve effective management with the current tools that we have with this disorder. Of course, the first question is what defines high risk? And usually it's a clinical definition and it's somewhat arbitrary. And usually it means seeing a patient where you anticipate their survival will be less than 2 years. And then the question is, what criteria will you use to anticipate patients who will have a short response duration, rapid proliferation, and ultimately succumb to the disease within a 2-year period of time? So there are multiple definitions of what constitutes high risk. There are those that relate to the IMWG definition, the myeloma working group. But when we think about what constitutes high risk, of course, just simple staging in and of itself is a measure of risk because it's a way to assess prognosis. And these are the patients who are associated with the shortest survival. So we have our standard staging system, which is a beta-2 microglobulin over 5.5. And in some trials, international stage 3 in and of itself, reflecting a high tumor burden, is considered high risk. The revised international stage 3 has added to the beta-2 microglobulin of 5.5 elevation of the LDH, which of course is an indirect measure of proliferation of the tumor clone, or genetics, which in the RISSS is 414 or minus 17p or 1416 or 1420. Not part of the international staging system of high-risk genetics is amplification of 1q21, which clearly is a high-risk feature present in nearly 20% of myeloma patients, but it isn't currently included in the RISS consensus criteria, but amplification as opposed to addition of 1q21 clearly is a high-risk feature. Also, certainly not part of the ISS criteria are circulating cells by flow. Plasma cell leukemia is a pretty old definition and relatively outmoded, which would be 10% plasma cells on a circulating peripheral blood film. But flow has demonstrated the ability to count 100,000 nucleated cells in under a minute. And it's been demonstrated that patients who have 500 circulating cells by flow have the same outcome as frank plasma cell leukemia. So if there's circulating cells in the peripheral blood by flow, a relatively simple technique, this also would be considered a high-risk feature. The proliferative index of the plasma cells, either by the labeling index, by BUDR, bromodeoxyuridine uptake, or Ki-67, is a very sensitive assessment of high risk because these are the patients who have high S phase, and so you end up with a high proliferation. These are the patients who are characterized by the notorious very rapid response and then very rapid relapse due to mutations and acquisition of new drug resistance genes during therapy. And although it's not a pre-treatment characterization, clearly patients who fail to achieve a partial response to novel agent-based induction, VCD, VTD, bortezomib Lendex, bortezomib thalidomide dex, bortezomib cyclophosphamide dex, with or without daratumumab, are known to have inherent chemotherapy resistance and are considered high risk, rapid progression, and inevitably median short overall survival. Other clinical high-risk features have been defined. Any patient who relapses within 12 months of the initiation of therapy is considered high risk. Patients who present with myeloma cast nephropathy that does not resolve after induction therapy, which in our practice is about 5% of patients, about 20% present with renal insufficiency at diagnosis. 3/4 of those patients will resolve, but there'll be 5% with persistent renal insufficiency, although their progression-free survival after first regimen is not shorter, their overall survival, probably because these patients don't tolerate and certain agents can't be safely given with persistent renal insufficiency, are considered high risk with short. Patients who have gene expression profiling defined high risk, which incorporates, of course, high risk genetics, are short survivors. Patients with central nervous system myeloma, myeloma meningitis, where you can see circulating cells in the spinal fluid, are short survivors with high risk. And finally, those patients who have extramedullary disease. So as you know, myeloma cells don't grow well outside the bone marrow microenvironment, and they require that microenvironment to sustain. Once a myeloma cell is capable of growing outside the microenvironment, in the lung, in the liver, in soft tissues, many of these patients express CD56. The presence of extramedullary disease is also considered a high-risk feature. So we need to understand that different trials use different criteria for high risk, and frankly, they're all valid because all of them predict a bad outcome. You see these patients in your practice if they present and fail induction therapy, or have persistent circulating cells or extramedullary disease, you cringe because you know that the outcome for these patients is going to be inferior. So this is the kind of risk assignment that's based on FISH and the international staging system. This is a review of 2,500 myeloma patients just to get some sense. So first, we look at the international staging system simply based on whether the albumin and beta-2 microglobulin, as you know, albumin greater than or less than 3.5 with a beta-2 greater than or less than 3.5 will give you stage 1, and then stage 2 is low albumin and low beta-2, or a high albumin and a high beta-2, and international stage 3 beta-2 over 5.5. And then you segregate those by high-risk FISH. And in this setting, this didn't include plus 1p Q21, but you get people into 3 categories. ISS1, normal FISH, are low risk. ISS3, but normal FISH, are intermediate. And ISS1 with high risk FISH are intermediate. And finally, ISS2 or 3 with high risk FISH are high risk. And when you do those numbers, you end up low risk 54%, intermediate risk 27%, and then the high risk, which of course is what we're dealing with today, 19%. So these are patients who have high risk FISH and either ISS2 or 3. And when you look at the 5-year progression-free survival for high-risk FISH, it's 9%. And so you have a very short progression-free survival compared to intermediate, which is double, and low, which is triple the percentage. And then when you look at the 5-year overall survival, the 5-year overall survival for high risk, which is 500 patients out of 2,500, is 9% and 28% overall survival. In the transplant eligible population for high risk, it's 38%, and for no transplants, 15%. And that just emphasizes how important stem cell transplant is for high risk myeloma. And later on in my discussion, we'll talk both about single and tandem transplant for this high risk group. Notice that although the 5-year overall survival is 28%, for intermediate it's 38%, and low risk it's 62%. And so really the high risk group is defined by very poor outcomes. And so in this schema, a simplistic way of defining high risk is international stage 2 or 3 associated with a high risk genetic signature by FISH. And so again, here's a second attempt at doing this. This is 3,000 patients subjected to the exact same. And this is just by revised international staging only. And so a revised international stage 3 high risk would be beta-2 over 5.5 and either in high LDH or a high risk FISH. And when you do it that way, 10% instead of 19% turn out to be high risk. And again, you can see the progression-free survival of the patients is 22%, and the 5-year overall survival is 40%. And this is classic RISS staging criteria with no segregation, as I did in the prior slide, reflecting how poor survival is. 5-year in this instance, 40% compared to 80% for patients who have ISS1, meaning standard FISH, good albumin, and beta-2 under 3.5, which represents 28% of the population. So this refers to the issue of the changing definition of plasma cell leukemia. When Kyle first described plasma cell leukemia. The definition that he used was based on the technology that was available 48 years ago. And the way Kyle defined it was a differential white count of over 20% plasma cells on the differential, or an overall circulating plasma cell count of 2,000. So if you had a 20,000 white count, you only needed 10% plasma cells. And so that was the criteria based on the evaluation. You did a CBC, you did a manual differential, counted plasma cells. And that's how we defined plasma cell leukemia, but there wasn't the way we do it today with a validation cohort and a confirmatory cohort. But with the introduction of flow cytometry, you can count 100 to 150,000 peripheral blood nucleated cells very easily. And if you look at a recent trial done at Mayo, 400 circulating cells out of 150,000, which is 0.26% by flow. If you look at their survival, it matches exactly Kyle's original plasma cell leukemia curve based on the diff. And so IMWG has evolved and is now adopting a definition of 400 circulating plasma cells by flow as part of the definition of plasma cell leukemia. And basically, if you look at patients with circulating cells, 67% turn out to be international stage 3 compared to 34% who just at random, that's the normal distribution. And when you look at these patients with 400 circulating plasma cells, 40% have a 17p deletion versus 11% in an unselected newly diagnosed myeloma population. So the circulating plasma cells is certainly not independent of stage, and it's not independent of high-risk genetics, but it's a very useful and relatively simple way of identifying patients with a bad outcome based on flow. So this is just a, again, demonstration that the revised international staging system is predictive for early progression, even after stem cell transplant. And so it just validates that staging is a very good measure of high risk. And you can see that in a stem cell transplant cohort that was identified as international stage, revised international stage 3, that the relapse-free survival median was under 1 year, and that at 2 years, less than 30% were progression-free. And so that's a relatively simple way of just using the known staging system as an assessment of who are the patients who are high risk. This is Mayo Clinic MSMART, you're all familiar with, and it's the way in which we've looked at high risk, and we've defined it in multiple ways. And then the 414, 1416, 1420, -17, mutation of P53, amplification of 1q21, revised international stage 3, elevated proliferative index, our S phase, and then gene expression profiling high risk. We've also moved to defining double and triple hit myeloma, the way in which we talk about lymphoma. So any two high-risk genetic abnormalities, probably the two most common would be a patient with 414 and -17p. But if you have a 1q21 and a -17p, that would be considered double hit. And triple hit usually is 1q21 as well as -17p, and then a translocation involving the immunoglobulin heavy chain locus at chromosome 14, and could be any of 414, 1416, 1420. And so that's your double and triple hit. And standard risk would be trisomies 1114 and 614. And this is how we have previously categorized the management of the transplant eligible patient that have the high risk features. And the way in which we've been approaching this is that if you're deletion 17p, we've been using bortezomib lendex, but of course, in many countries, lenalidomide is not a feasible induction, so it would be bortezomib thalidomide dex, followed by a single or tandem transplant. And of course, DARA is now part of the consideration of induction for high-risk patients. But importantly, maintenance has changed for us. We're using 2-drug maintenance in the high-risk population. And that would be bortezomib-based, where we'd normally give bortezomib subcutaneously once every other week. But we would also include with this either an IMiD-based treatment that could be thalidomide or lenalidomide indefinitely until progression. And most recently, we will consider daratumumab bortezomib-based maintenance. For patients who have the 414, 1416, or 1420, we're now considering carfilzomib with lenalidomide or thalidomide dex induction because of some of the advantages carfilzomib has shown in high risk, which I'll show a little later on, single or tandem transplant, and then 2-drug maintenance with carfilzomib or bortezomib combined with an IMiD or daratumumab until progression. And I'll be going over some of the studies that lead to these MSMART conclusions that I'm showing. So I want to go over the master trial that was presented by Luciano Costa, both at ASH 2019 and 2020. And this was a single-arm phase 2 trial of treatment-naive myeloma with measurable disease and a creatinine clearance greater than 40. And he enrolled 81 patients into this. And what they looked at was induction with daratumumab, carfilzomib lendex for 4 cycles, followed by autologous stem cell transplant. And these patients underwent MRD assessment after each treatment phase, and that was MRD at sensitivity 10 to the minus 5, and further MRD assessment at 24 and 72 weeks after the end of therapy. All patients received consolidation with daracarfilzomib lenalidomide dex for 8 additional cycles with MRD between each one, and everyone received lenalidomide maintenance therapy. And the goal here really was MRD negativity, which for patients who have high-risk multiple myeloma is essentially the only predictor of a superior outcome. Although MRD negativity is certainly not required for standard risk myeloma and patients with myeloma evolving out of MGUS, failure to achieve MRD negativity in a high-risk subset is virtually always predictive of early relapse. So they used MRD negativity using next generation sequencing as their primary endpoint. Their secondary endpoint was also IMWG defined response, progression defined as the loss of MRD negativity. And so just a little bit about the baseline characteristics of these patients. You can see that these patients had 20% of the patients international stage 3 and high-risk FISH in 28% of the patients when looking at the classic criteria of 414, 1416, or minus 17p. But if you add to this the 1q21 amplifications, their high risk was 52% of patients, and 19% of the patients had an elevated LDH. So this is the MRD response based on genetics, both at 10 to the minus 5 and 10 to the minus 6. So I'll draw your attention to the far right 3 columns. When you look at achievement of MRD negativity after induction, it was 38%. At the end of transplant, this high-risk group was MRD negative, 67%. And by the time they got to MRD-directed consolidation, although now we only have 12 patients, 83% achieved MRD negativity at 10 to the minus fifth. So again, this was KRD-based, KRD consolidation and transplant and IMiD maintenance for all patients. And even at 10 to the minus sixth, 42% of the patients achieved MRD negativity. So they achieved a very, very good outcome with intensive therapy that was both triplet-based and transplant-based. So here is the same data, just kind of showing what happened with the MRD negative directed consolidation in the overall cohort. And you can see that nearly 63% achieved MRD negativity at a 10 to the minus fifth. And so this is just one of the demonstrations of using carfilzomib as kind of a cornerstone of therapy for those patients who were FISH-determined high-risk patients. So here again, this is the best response by treatment phase, and you can see how MRD negativity increases at every single step. And it demonstrates two important aspects of this trial. One, that transplantation increased the MRD negativity rate, the stringent complete response rate, from 31 to 81%, and consolidation increased it to 95%. And so, you know, people continuously ask about the role of stem cell transplant in the era of novel agent therapy. And this and other studies that I'm going to show clearly demonstrate that transplant, and perhaps tandem transplant, really maintains a very important role of achieving a stringent complete response. And you can see that high-risk patients in this with the 414, 14, 16 deletion 17p, after induction, you have 25%, but by the end of transplant, it's nearly 85%, and by the end of consolidation, 91% are MRD negative. Also, when you think about what the toxicity was, it was really quite safe. I mean, cytopenias are clearly expected in patients after this type of treatment. But the truth of the matter, when you look at grade 3 toxicity, you have about 1 in 8 patients developing serious infections. And in this entire group, there were only 2 deaths, one due to pneumonia 9 days following stem cell transplant, which is the height of granulocytopenia, and one patient who died suddenly 58 days after transplant. Otherwise, the master approach of KRD transplant consolidation maintenance is really quite a valuable intervention. So their conclusions, and they updated this, but the results didn't substantially change at ASH in Atlanta, was DARA KRD transplant, DARA KRD consolidation was quite effective, with 39% achieving a stringent complete response and 95% MRD negative. And that this response was achieved both in the high risk and standard risk, with very few patients having to stop treatment due to toxicity. And that the delivery of this resulted in MRD negativity. And those final results are being published this year at ASCO. So this is weekly KRD DARA. This is 8 cycles of induction. So I just want to kind of go over what goes on in this clinical trial. So here the DARA was given weekly for 8 weeks. Then it was given every other week for the next 16 weeks. And then after a total of 24 weeks of treatment, it goes to every 4 weeks. Here, carfilzomib is given, and the dose here is 56 milligrams per meter squared, Many of you may be using 70 milligrams per meter squared on a weekly basis. And here the carfilzomib was given weekly with lenalidomide 3 weeks out of 4 at a dose of 25 milligrams. And dexamethasone was given 40 milligrams weekly for 16 weeks. And then the dose was reduced by 50% to 20 milligrams weekly. For fit patients, stem cell collection was performed after 4 to 6 cycles, but immediate transplant wasn't performed. After collection, therapy was resumed for a total of 32 weeks of induction. And when they compared people who were getting biweekly and weekly carfilzomib, efficacy and safety was the same. And so the biweekly carfilzomib arm was discontinued and carfilzomib was given weekly. And that's kind of the standard for this trial, is weekly carfilzomib. And here's some of the preliminary results that have been published. The weekly KRD DARA arm was fully enrolled. 61% were female, 49% were high-risk FISH genetics, and 30 of the 41 were evaluable for the primary endpoint, which was MRD negativity after 8 cycles. Median follow-up is still relatively short of 8.6 months. 24 patients completed all 8 cycles, and high risk was considered by FISH or by a gene expression profiling array in enriched plasma cells, and you can see it included any immunoglobulin rearrangement of the heavy chain on 14, -17p, and 1q21 amplification. MRD negativity was achieved in 77%, which was the primary endpoint of the study, and the median time was 24 weeks. And using conventional criteria, VGPR or better was achieved in 97% and an overall response rate of 100%. So it's DARA, weekly KRD for 8 cycles. If you looked at the 24 of 30 patients that completed all 8 cycles, MRD negativity was achieved in 75%, VGPR or better in 92%, overall response rate 100%. And this is the swimmer's plot of the trial that was PI'd by Ola Landgren, just to demonstrate the high rate of MRD negativity that was achieved after 5 months of follow-up. And you can see only one patient, number 6, had progressive disease and went off study among the 41. And you can see that the response rate was indeed overall 100%, and the VGPR or better are the yellow, and you can see that was achieved in virtually all patients. Again, the primary endpoint was MRD negativity as a best response after 8 cycles, and this was achieved in 23 out of the 30 patients. And at the time of the report, none of the patients who had achieved MRD negativity have relapsed. Among patients over the age of 65, the MRD negativity rate was 75%. None of those patients had progressed either. So this was, again, DARA KRD without transplant. And these are the patients over the age of 65 after 8 cycles. So the conclusion in this trial was that MRD negativity was 77%, and this was without an autologous transplant. So the master trial, that was with transplant, and the Landgren Memorial trial without transplant. Personally, as I'll show you, I think transplant's really important in this group. That weekly carfilzomib is convenient, deep responses, and really toxicities at weekly carfilzomib was really the same as standard of care biweekly carfilzomib 1, 2, 8, 9, 15, 16. The European Myeloma Network presented at the ASH 2019 primary plasma cell leukemia using carfilzomib and lenalidomide in patients under the age of 65. And this was 15 patients with plasma cell leukemia. And so first they looked at these patients over the age of 66. And the way they treated those patients was to use carfilzomib, but at a reduced dose of 36 milligram per meter squared, not 56 or 70. And they used 25 milligrams of lenalidomide for induction. And for maintenance, the dose of lenalidomide was reduced to 10, and the carfilzomib dose was reduced to 27 for tolerability. Notice here the carfilzomib was given twice a week, 1, 2, and 15, 16, rather than the weekly schedule. And treatment for these patients was until progression. So it was indefinite therapy. They stayed on indefinite maintenance. For younger patients on this trial, age 18 to 65, 4 cycles of carfilzomib Lendex with 25 of Len, collection and immediate transplant tandem. They received 2 transplants, then were consolidated with 4 cycles of carfilzomib Lendex with carfilzomib at 36, and maintenance was Len 10 and carfilzomib 27 in the old style of 1, 2, 15, 16, so 2 weeks out of the month. And when they looked at efficacy, the response following 4 cycles of KRD induction for the first 15 patients under the age of 65, CR or better was achieved in 33% of the patients, with an overall response rate of 93% and a VGPR or better of 80%. And so this was highly effective with carfilzomib-based therapy, tandem transplant, and maintenance. So their conclusion was that KRD, here no DARA was used, produced a very high response rate after 4 cycles, CR in 33% with no early deaths. And the toxicity usually occurred during the first cycle of induction, mostly hematologic, and responded to dose modification. And their recommendation for this high-risk plasma cell leukemia group was KRD, and anticipate that they will see a better survival compared to other patients with plasma cell leukemia who typically have survivals of 1 year or less. This is a review just of Mayo patients that we looked at in patients who had a minus 17P. So we selected patients with the minus 17P and looked at bortezomib, cyclophosphamide, dexamethasone versus either carfilzomib, bortezomib, and either pomalidomide or lenalidomide induction. And what you can see is that in this group, not a big group for sure, I mean, we're talking about 112 patients, and you can see that the patients who received VRD or VTD or KRD did better than bortezomib, cyclophosphamide, dex. The point of this trial was to demonstrate that cyclophosphamide induction in minus 17P was inferior to an all novel agent based induction with a proteasome inhibitor and an IMiD. And so we've stopped using alkylating agents as part of the induction therapy of patients with high-risk disease as defined by minus 17P. This is the progression-free survival looking at maintenance therapy in the minus 17P cohort. And I had alluded to a little earlier that at Mayo for high-risk patients, we're using double agent maintenance, either bortezomib, lenalidomide, daratumumab, lenalidomide, occasionally ixazomib, lenalidomide, compared to single agent maintenance, which is almost always lenalidomide. And you can see that if you have high-risk genetics defined by -17p, the progression-free survival was better with 2-drug maintenance. And I think that randomized trials that are ongoing will likely demonstrate that for high-risk subsets, 2-drug maintenance therapy is superior to 1-drug maintenance. And the trials that are currently active in the US are darolutamide maintenance versus len, ixazomib len versus len. And there are trials looking at carfilzomib len maintenance versus len. And so these will certainly read out, but I guess that in the high-risk subset, 2-drug maintenance is going to become the norm for these patients. So this was also a look, this is an older trial looking at triplet carfilzomib lendex, and this final report has been published versus lendex. And this is looking at patients with high risk only. So 100 patients that were randomized, 48 to KRD compared to 52 with just doublet RD, showing that triplet induction with carfilzomib-based therapy was superior both for progression-free survival with median survivals that were far superior in patients that received carfilzomib-based therapy. And so this was a global trial of KRD versus RD, and it really did favor. And you can see that the hazard ratio was between 0.65 and 0.7 for these groups. In the top, you're looking at only the high risk. In the bottom, you're looking at all patients that were accrued. This is the Endeavor trial that looked at carfilzomib dexamethasone versus bortezomib dexamethasone. This is for relapsed disease, but this was stratified by cytogenetic risk. And here I'm showing the high-risk cohort, which was 97 that got carfilzomib dex versus 113 that got bortezomib dex. And you can see that the p-value was, in this case, was 0.0075 that favored the use of carfilzomib dex, which was the solid blue line, versus bortezomib dex, which was the solid red line. Now you can see how high risk in both instances was inferior to standard risk. So high risk carfilzomib dex was about the same as low risk bortezomib dex. But the point of this trial was to demonstrate that carfilzomib was a superior proteasome inhibitor to bortezomib in relapsed patients with high risk genetics. But this was prospective and randomized. And you can see how the hazard ratio for the high risk was really improved with that hazard ratio of 0.646 and an improvement in the progression-free survival from 6 to 8.8 months. This is high-risk genetics and stem cell transplant, looking at MRD detection by flow, comparing standard risk to high risk, looking both at progression-free and overall survival. And you can see that patients who have high-risk disease after transplant have a progression-free survival of approximately 20 months if they don't achieve MRD negativity. But if they do achieve MRD negativity after transplant, they have a median progression-free survival of approximately 44 months, and that is statistically significant. So it becomes important. If you look at the blue line between the two curves, it really is important to try and get these patients to autologous stem cell transplantation as a key facet of management. This is all of the slides combined, and you can look at high-risk disease and MRD negativity, which is the solid blue line, and high-risk disease MRD positivity, which is the dashed blue line. And you can see the dramatic difference in their progression-free survival. Obviously, the patients that do the best are standard risk MRD negativity, but for the high-risk group, you can see that achievement of MRD positivity is an important goal for this subset of patients. This is a presentation at ASCO, just looking at 3 groups of patients with high-risk cytogenetics, just demonstrating how outcomes have improved over time. And as you can see, 2004 was the very, very beginning of bortezomib. And 2008 would have been bortezomib and len. In 2013 would have included pomalidomide and patients with carfilzomib, but not daratumumab. And it's just a demonstration how overall survival currently is improved dramatically with the introduction of novel agents over time. Again, we're looking here at 4 induction regimens from the original trial of RD versus DRD in elderly non-transplant eligible patients for multiple myeloma. And so if you look at the high risk and standard risk, looking at Dara-Lendex versus Lendes, you can see that the patients who got Dara with high risk actually did better than patients who got RD and were standard risk. And when you look at high risk Dara RD versus RD, so Dara RD for the elderly patients had a median progression-free survival of 26.8 months. High risk with the doublet of RD, median 8.3 months. And so triplet Dara RD in a non-transplant eligible population, which was 26.8 months, which is that solid red line. Looking at the solid red line, and the RD high risk was the dashed red line. So here it was really quite important that Dara reduced, with the hazard function for Dara was 0.34. And so for high risk, this was one of the first demonstrations of the importance of daratumumab in its ability to manage high risk disease. Now we're looking at, again, progression-free survival, again here on VD versus DVD. So the first trial was DRD versus RD. Now we're looking at DVD versus VD. And again, you're seeing a pretty similar situation here, that by the addition of daratumumab to bortezomib dexamethasone in the high-risk population, you get a survival median of 12.6 months, and the hazard function for the high-risk subgroup is 0.41, favoring the addition of daratumumab. So again, doublets can't be used in high-risk disease. Here, your choice is based on this was Dara-VD or Dara-RD. So then we come up to is, okay, what's the role of tandem stem cell transplant in high risk? And we get different results depending on what country you're in. And we're going to go over 2 trials. We're going to go over Cavo's IFM trial and the United States randomized trial of single versus transplant. And we're going to talk about the different eligibility criteria, which I think were really important in impacting the outcome of tandem versus single transplant. So we're going to compare here the EMN02 versus the Stamina trial. On the right, you're looking at EMN02 HOVON 95. Now, this is not the high-risk subgroup. This is all patients. But even with all patients that were compared, you can see a trend for improved progression-free survival for patients that received a tandem stem cell transplant. When you look at overall survival, those differences are a bit more subtle, but still achieved statistical significance for patients who received tandem transplant. Now, those results were very different from the US Stamina trial, where progression-free and overall survival were not statistically significantly different between patients that received a single autologous transplant followed by maintenance, a single autologous transplant followed by bortezomib, lenalidomide, dexamethasone consolidation, and patients with high risk that received a tandem auto transplant. So in the European trial, survival benefit. In the US trial, no survival benefit. Why would that be? Well, here's the high risk subset, and these look very, very different. So here, this is the CAVO European trial looking at tandem transplant of standard versus high-risk genetics. And you can see that high-risk genetics clearly don't do as well as standard genetics, even with tandem transplant. This is the Stamina trial looking at overall and progression-free survival. And again, in the high-risk genetic subgroup, no difference. So we have very fundamental differences in the readout, depending if you look on an American-based study versus a European-based study in terms of the value of tandem transplant. This is the single autologous transplant arm in the European study showing standard versus high risk and how poorly they do. Yet here you look at the tandem transplant arm in the European study, and you can see that in the European study, if you get a tandem transplant and you're high risk, you end up with identical outcomes. So in the European CAVO study, application of tandem transplantation eliminated the adverse impact of high-risk genetics. And so the conclusion here, looking at the study, is that a tandem autologous transplant improved overall survival in newly diagnosed myeloma who had high-risk genetics when compared with single transplant. So we're getting different readouts depending on where a trial is conducted. Why is this? Well, let's look at the eligibility criteria for the different trials. In the European trial, patients had to have single induction therapy with VTD. If they didn't respond to VTD, they were off trial. All patients then who had responded went to collection and immediate stem cell transplant within 6 months. The US trial had a fundamentally different design. Patients weren't randomized until they completed induction. Patients could have gone on trial within 12 months of diagnosis. Patients who failed a first induction could get a second induction and still be eligible for enrollment. So there's a very fundamental difference between American and European, is that 2 induction regimens were allowed. And where the European trial was limited to VTD, patients in the American trial could have gotten VTD, VRD, KRD, DARA-KD. There were no limitations on the nature of the induction or second induction therapy. And I think the availability of novel agents had a very profound impact on the differences in the outcome, so that in Europe, where VTD was the required induction, tandem transplant was beneficial. In the US, where the availability of multiple novel agents was much less restricted, tandem transplant didn't add. So I think both trials had accurate results. It's not one trial right and one trial wrong, but both trials were right based on the availability of different agents for induction. So I want to touch about extramedullary disease and a publication that looked at extramedullary disease as high-risk myeloma. First of all, in extramedullary, outside cortical bone, high-risk genetics were found in approximately half of newly diagnosed patients coming to transplant. And in this trial, in patients who had extramedullary myeloma diagnosis, tandem transplant improved survival in patients who were both extramedullary and high-risk genetics compared to single transplant. They also looked at autologous followed by allogeneic transplant with extramedullary disease, and that appeared, it was borderline, improved compared to single transplant, but more data is needed. Currently, I'll tell you that at Mayo, we're not recommending allogeneic transplant for high-risk patients if novel agents are available. If novel agents aren't available, then the use of allogeneic transplant is a legitimate consideration. Just a little touch regarding kind of the pathophysiology that leads to plasma cell leukemia, extramedullary disease, and central nervous system multiple myeloma. And you can see that there's a whole sequence of initiating genetic events, usually involving chromosome 14. The bad ones are FGFR3, CCND3, CMAF, and MAFB. Secondary events that occur after diagnosis are the CKSP1, the amplification of 1q21, or deletion of 1p, deletion of 17p, which tend to be acquired mutations after diagnosis, and then terminal changes, which include MYC translocations, NRAS, KRAS, BRAF that occur that lead to these changes. And you can see also how in the microenvironment changes occur that lead to the progression from medullary myeloma to extramedullary myeloma. And I want to emphasize how CD56, which is an important adhesion marker, loss of leads to the developing of extramedullary disease, and then subsequently changes in PDGF that lead to terminal disease. So now just discussing a little bit about MRD negativity resulting in improved prognosis in high-risk multiple myeloma. And there are multiple studies that were presented at ASH showing that MRD positive high-risk patients have very poor outcomes, even if they're complete responses. There's a very big difference between MRD positive complete response and MRD negative complete response. And improved progression-free survival is seen in high-risk genetics that achieve MRD negativity that has been reported in most studies. And it appears that if you can get to MRD negativity, it will negate the adverse prognosis of high-risk genetics. And then, of course, then the question is, what is the best induction therapy that will give you the highest percentage of MRD negativity? Just hold on a second. I just want to be sure that I've just 2 seconds. And so with that, I just want to conclude the discussion, and then I would like to, I've stopped sharing, and so I'll please turn it over back to you, Dr. Agarwal, for questions and answers and discussions. I want to thank you all for your attention. So it's a pretty dense topic.
Thank you very much, sir. Fantastic. Enjoyed listening to you. Complete coverage. We have our Indian colleagues here who would like to discuss with you. Dr. Ritu Gupta.
Hello, good evening. Thank you, Dr. Gertz, for such an educative lecture. Can I make a couple of comments, and I have a few questions? May I?
Oh, please.
Okay. So this talk started with the very first slide which says that the definition of the high-risk myeloma is survival less than 24 months. Excellent, because see, we are currently, as the new biological features are being determined, we are realizing that as the therapy is improving, as we are getting more novel agents, the previously accepted biological features of high risk are slowly losing their edge, or rather their sharpness for the high risk disease. So one example in that is translocation 414, which a few studies have shown that after the addition of bortezomib, the the high risk impact of 414 is not so much. And in the MSMART 2.0 classification, risk stratification also, your group has put the 414 into the intermediate risk. But now today in 3.0, I see that it is again in the high risk group. So can you throw some light onto it? Is it because it's part of double hit or triple hit myelomas, and that's why you're calling it high risk? Or is there any other reason?
No, you're quite correct. I mean, all of the therapies that we have and what constitutes increased risk will constantly change as therapy evolves. So the easiest example would be looking at chronic myelogenous leukemia. Before the introduction of TKIs, we had 5 different staging systems from CML that were in competition of what constituted high-risk CML. Then, of course, imatinib becomes introduced, and all of a sudden, everything changes. And now all we really care about is whether the patients end up with BCR-ABL gene of 0. Obviously, we're making recommendations where solid data is lacking. The move, and you're quite correct, because there is an interaction where hyperdiploidy tends to attenuate a little bit. That hyperdiploidy in 414 is better than 414 alone. And so it just shows how complicated it can get, because now you've got interactions between different, they're not independent, that one affects the other. I will tell you that at least in the United States, the movement has been for indefinite maintenance therapy in patients both standard and high risk if they tolerate it. You know, when we talk about giving bortezomib maintenance therapy every other week, we're not doing that in patients who have active painful neuropathy or progressive sensory loss. We're not giving forever lenalidomide in the face of intractable diarrhea, or patients who are having problems with cramps and skin rashes. I mean, so obviously toxicity is playing a role. But right now, if you look at ECOG trials and how we're handling it, the only patients who are being considered for finite duration therapy is, we have a current trial that looks at patients at 2 years who achieve MRD negativity. And if your MRD negativity is present at 24 months, we're randomizing patients to stopping maintenance or continuing maintenance, which of course is very much like the old CML studies, looking at patients who develop molecular CR versus no molecular CR, molecular CR randomized to stop their TKI versus continue their TKI. We're doing the same thing. But in our trials, patients who are not MRD negative, they're continuing maintenance therapy indefinitely based on tolerance. So there's a lot out there about 2 years maintenance, 3 years maintenance. In practice, what we're seeing is indefinite maintenance based on toxicity.
This is true for post-random transplant or allo transplants as well, for maintenance.
Well, it is true post-tandem transplant, but I have to tell you that the number of allo transplants we're doing is so very small. I mean, we've really moved away from allo transplant unless the patient is exceptionally young. You know, just like was mentioned about the value of genetics, as we get more and more novel agents, our utilization of allo transplant has fallen substantially, because in our experience, the most common cause of death following allogeneic transplant in multiple myeloma, the most common cause of death is still multiple myeloma relapse. Our ability to achieve long-term control with allotransplant is not good. And the most common outcome we have in our practice following allotransplant is recurrent myeloma in the face of graft versus host disease chronic. And so we've really moved away. We're doing 1 or 2 a year compared to 250 auto transplants per year. And so I wouldn't be able to comment on maintenance therapy after allo because we're applying it so sparingly now.
Thank you so much.
Thank you.
Thank you.
Thank you. Dr. Nidhi.
Thank you, Professor, for that enlightening talk. My question is regarding what are your thoughts on the use of CAR T cell therapy in the plasma cell leukemia or very high risk myeloma patients? Would you consider incorporating CAR T cell therapy early on rather than using it in a multiply relapsed patient?
Well, that's a problem because most of the trials that we have, first of all, we have 2 approved CAR Ts, right? Ida-cel, Seda-cel, but those require 4 prior lines of therapy relapse, or we can't get reimbursed unless it's 4 prior lines. So commercial, that really isn't a possibility. For the investigational trials that we have access to us, it's also, they're usually phase 1, phase 2, where the phase 1 is dose escalation of the number of lymphocytes infused, also are limited to patients. And the concept that you have about, well, what about consolidation of plasma cell leukemia patients in response has a lot of merit to it because we're transplanting those patients after response. And the question about applying immunotherapy at a point where the disease burden is at the lowest we're likely to get it has a lot of merit. But currently, in all the studies we're participating with, that's not available. And of course, that same thing is going to apply to bispecifics, as well as antibody conjugates, as well as trispecifics, about using it in high-risk patients before they've developed recurrence. And one of the issues for all of these research trials that we have is they have to have measurable disease. So if they achieve a complete response after induction and transplant, again, they're not eligible. You know that this is going to come, that we're going to be doing it. And we're probably going to be doing trials where there's going to be induction and then they'll be randomized to CAR T or auto transplant. But right now, we don't have access to this. There's no doubt, given the efficacy of CAR T therapy, taking it to patients who are going to have minimal disease, high risk, and of course, minimal disease will give them their lowest risk of developing cytokine release syndrome or ICANS, is highly desirable for sure.
Thank you.
Thank you, Dr. Nidhi. Dr. Shilpa.
Thank you, sir, for the wonderful talk. My one question is, when you say MRD monitoring, does this mean you're usually doing in your center, whether it's NGS based or is flow based MRD? And how frequently do you monitor these MRDs? Like day 100, all of us know, but beyond day 100, like how frequently? And do you change your maintenance strategy based on the positive MRD at a later date? Is there any role for that?
Right. So those are great comments. At Mayo, all of our MRD measurement is done by flow. Now, the question is, are you on a trial or not on a trial? If you're not on a trial, quite frankly, I don't feel very strongly about surveillance imaging or surveillance bone marrow if they were secretory at diagnosis. Usually, if patients presented with a light chain of 1,000 milligram per liter, and that you've brought them down to normal, I'm generally not doing surveillance studies looking for PET relapse without a light chain relapse. I'm just doing the assessments by the light chain only. On trials, there are requirements for surveillance every 6 months, although frankly, I don't know how much that's getting. Now, for sure, there are publications that show that patients who go from MRD negative to MRD positive, CR, have a shorter progression-free survival than patients who are MRD negative, CR. So that data has already been published. But I don't know that that helps you with management. I don't think that necessarily tells you that someone who's completely asymptomatic on maintenance therapy, who develops an MRD positive continuous response, becomes a candidate for immediate reinduction therapy, just like a patient who's in a CR who develops reappearance of a small monoclonal protein in the serum needs instantaneous switchover. I certainly don't in my practice. I have someone who's 80 years old who has reappearance of a monoclonal protein that's asymptomatic. I'm going to continue to observe them without changing therapy until I see what the velocity of the rise of the protein is. Because some of those patients will get a year to a year and a half before the relapse is clinically significant. In other words, for these patients, progression-free survival and time to next therapy are not the same thing. And in a lot of these patients, I'll watch them. Now, having said all of that, I think the future of MRD measurement is not going to be in the bone marrow. There's a lot of research that's going on at Mayo and other centers looking at mass spectroscopy of the serum. And mass spec, which of course sorts the proteins by molecular rate rather than our traditional sorting of proteins by charge, which is a 120-year-old technology. We're doing that by mass spec, and we're seeing quite a few patients where we can detect the protein by mass spec, even in MRD negative states. And ultimately, I think mass spec MRD on the serum will replace MRD measurements on bone marrow plasma cells, which of course will give us a cell-free measurement of MRD negativity, will avoid the requirement of the bone marrow. Mass spec on the serum costs rupees. It's really inexpensive and can be done monthly, where you can't do the bone marrow. So I think the future is going to eliminate all we're doing with NGS and all we're doing with flow on the bone marrow. It will be replaced by MRD, by mass spec analysis for absence of the protein in the blood.
Thank you.
Thank you.
Any other question? Okay, I have a couple of questions for you, sir. Should I take it that there will be a minimum of 4 drug induction for all the various types of high-risk myeloma that you described?
So that's important. And I think the Mayo consensus, where drug availability isn't the big issue, is that for high-risk disease, we've moved to quadruplet induction, and that's either DARA VRD or DARA KRD as induction for legitimate high risk. But, you know, again, does that mean if you have an isolated 1Q21, is that going to be 4 drug induction? And that consensus hasn't been settled. But in patients who are truly high risk, by the definitions that we understand, high tumor mass, circulating cells, extramedullary disease, myelomatous meningitis minus 17P, those high risk features, those patients are getting 4 drug induction at Mayo.
Right. The second question is, should you put all of them on carfilzomib as against Velcade?
That's a tricky business too, and it's become even more complex because bortezomib is available generically, and the cost to patients is much, much less than carfilzomib. So there's a pharmacoeconomic issue that goes on beyond just comparing the slides. And you know, you have to remember that the ECOG trial that looked at VRD, KRD showed absolutely no difference at all. And there were some high-risk patients in that group. So this business about KRD, VRD, the data is not all that strong, and there's a lot of inferences that are being made about the superiority of KRD to VRD. Quite frankly, I think if you look exclusively at the data, I think if you were high risk and got quad therapy with Dara-VRd and kept K in reserve for progression, I don't think that that could be criticized.
Right. 3 drugs, 4 drugs, and then what about optimum trial? 5 drugs, adding alkylating agent?
Well, you know, we did a trial. This is tricky as well because the toxicity, the 5th drug is usually an alkylating agent. And from a toxicity standpoint, it adds a lot. I mean, there's more mucositis, alopecia, cytopenias. And then when you get that, you start compromising. If you get cytopenias, you're dose reducing other drugs as well. And when we did the original 4-drug versus 3-drug trial at Mayo, we did not see any benefit of adding the alkylating agent. And quite frankly, I personally am not prepared to add that. It gets hard on patients. And then, you know, I start wondering if we add alkylating agents early in induction, are we going to increase the risk of second primary malignancies? And we haven't had long enough follow-up to see what's going on. You know, as it is, we're starting to see, we used to see therapy-related myeloid neoplasm in 1% of our population of auto transplant myeloma. Well, it's doubled now to 2% we're seeing. And if you do 250 transplants a year, we're now seeing 5 therapy-related myeloid neoplasms in the myeloma population, and their outcome is pretty bad. And I mean, that's really starting to concern me as we're seeing higher and higher MRD negativity rates, what the role of the increased risk of second malignancies is. And so outside of a clinical trial, I'm not giving 5 drugs. I just think it's really quite overwhelming for patients, and the toxicity profile for patients who otherwise can expect very high MRD negativity rates are not currently justified. So it's not in my practice.
Right. Now, as 4-drug induction followed by autologous and double drug maintenance give better results in a high-risk myeloma, you think that we can cure more low-risk myeloma if we are aggressive with them?
Yeah, so that's always the question, is that if it's good for high risk, won't it even be better for low risk? And I guess a lot of that depends on whether your goal is cure, if that's really realistic in multiple myeloma, or whether your goal is to convert multiple myeloma into a chronic disease where patients will die of some unrelated disorder with their disease in some MGUS-like state. You know, I'm old enough to, I'm kind of jaundiced thinking about cure for myeloma. I don't know that it's a curable disease with our current technology. If you look at every MRD negative curve, most of them still don't have a plateau. They do better than everybody else, but you still see at 36 months, 40% of the patients have relapsed. And as we follow, I deep down believe most will relapse. I mean, even if you go back to Total Therapy 2, Barlaghi 1985, 10% of those patients are 20-year survivors, you know? So there's always a group that are, if you will, functionally cured. But I don't know if I believe in cure. You know, even in the allogeneic long-term survivors, they're long-term survivors, but they still have a persistent monoclonal protein. So they're in a plateau, but they're not in the CR. They're just long-term survivors. I like to really, when I talk to patients, I think it's disingenuous and dishonest to say, we're trying to cure you. I never use that term in the office. I think it's wrong. And I tell patients our goal is long-term survival and to live with the disease. And I think that's the goal. And if that becomes the goal for standard risk patients, or patients particularly whose myeloma develops 7, 8, 10 years after an MGUS, so they've already been defined as biologically indolent, I tend to be less is better. I would rather give someone a triplet induction, let's say VRD, transplant R maintenance, then second line, if they relapse on R, will be Dara VD, and if they relapse on that, it's carfilzomib POMD for my third line. My fourth line might be CAR T, but with those types of treatments, there are a lot of people we've got who are out 15 to 20 years. And I'm not wasting my time talking to them about a cure, which I personally don't believe. And when people say the goal is curative, trust me, I don't think that's being honest with our myeloma patients. I still tell them incurable disease.
Perfect. Somebody relapses with one single bone lesion. Can you just radiate it and leave it?
Oh, hell yeah. I mean, just those patients, even if they relapse with one bone lesion and 10% plasma cells, it all depends. So did the one bone lesion occur 3 months after the completion of transplant, or did it occur 3 years after? If it's 3 years isolated, I go, your myeloma's relapsed, you are going to need systemic therapy, but I don't know when you're going to need it. I will radiate that and observe. They're all going to progress. I don't tell them that, well, maybe that'll be the end of it. But if I can delay second line therapy for 12 to 24 months just by a single course of radiation, I think that's highly valuable. Obviously, there's a difference of one bone lesion, 40% plasma cells, and one bone lesion, 5% plasma cells. So that all interplays in it. But if you ask, is there a subset of patients that will recur with a single bone lesion? Absolutely. And this whole issue of, let's talk about newly diagnosed myeloma, showing up with a single bone lesion, 15% plasma cells in the bone marrow. When I say single bone lesion, I mean by PET. I'll radiate those patients and observe them. They have multiple myeloma. There's no question. It's not solitary plasmacytoma of bone with over 10% plasma cells is myeloma. I'll still radiate those patients. And it's not unusual that you'll be able to observe those patients 24 to 36 months before they get overt disease. And if I can delay chemotherapy for 2 to 3 years, I think I've done the patient a real service.
My last question is, these bone modifying agents, we give them for 2 years, 3 years. Can one continue them indefinitely? Does it help?
So this is a really important point. So let's look at the original trial of pamidronate. What was the patient's therapy in the original pamidronate trial? 70% were melphalan and prednisone. And then we were able to demonstrate that pamidronate helped reduce skeletal events. Now we go to zoledronic acid. What was the trial? Was the trial that it reduced skeletal events? No, it was non-inferior to pamidronate. So we moved to zoledronic acid. Then we moved to denosumab, and the comparator arm again was how it compared with zoledronic acid. So we talk about how prognosis and staging changes based on therapy availability. Well, the incidence of skeletal events has changed unbelievably in the last 15 years. Now, obviously, patients present at day 0 with whatever they have: multiple compression fractures, rib fractures, cortical erosion in the humerus or femur. In the old days, when we gave melphalan prednisone thalidomide, melphalan prednisone bortezomib, you needed skeletal modifying agents because these patients were at high risk. But I'm telling you, now that 60% of your patients are achieving CR and there are no or minimal plasma cells there making cytokines that are further damaging the bone, the number of skeletal events that I've seen in my practice with novel agent induction has plummeted. I mean, there are patients developing new bone lesions while they're still in plateau after triple agent induction. It's very, very low. And so I'm beginning to surmise that the need for all of these modifying agents is in decline. Now, please don't expect the pharmaceutical companies to sponsor a trial about when you can discontinue bone modifying agents, because they're not interested in it. But I'm telling you that in patients who achieve CR or better, I'm discontinuing them at a year, And you all know that there have been trials that show pamidronate 90, the same as pamidronate 30. and trials that show that bisphosphonate quarterly is the same as bisphosphonate monthly. So at the end of the day, I'm certain this is a situation where less is better. And I think the decision about supportive care and bisphosphonates should be based on response depth. A person who achieves PR, 75 years old, M spike goes from 4 to 2.2 or 1.8 PR. Those patients have a residual plasma cell population that likely is continuing to make IL-1 beta and IL-6, and they're at risk of skeletal events, and those patients are going to get continued bisphosphonates quarterly. But patients who achieve an MRD stringent CR, I don't know what I'm doing with bisphosphonates after they get a year of treatment, because they no longer have a source of agents that will continue to activate osteoclastic activity and continued bone loss. I mean, when's the last time you saw a patient who was in a CR come into your office with a new skeletal event? And all of a sudden they say, oh, my back is killing me. I can't move. I can't twist. It's really, really unusual. So I've been using response-directed duration based on what is their risk of ongoing production of, DKK1 if there are no plasma cells.
Perfect. Thank you so much for.
You bet.
Well, yeah, fantastic. Any questions from anybody? Okay, sir. Then that's the end of it. Thank you.
Oh, that's my pleasure, Dr. Agarwal. I hope I can come back to Mumbai one day.
We are almost free of COVID now.
Are you?
Present wave is getting over.
Well, don't send anyone to China. I'll tell you. So we're not there yet, but hopefully when travel resumes, I'd certainly like to come back and visit you all.
Absolutely. Dr. Alka, you have a question.
Thank you, sir. I just have one question. I want to know your experience about managing a high-risk multiple myeloma who has failed CAR T-cell therapy.
Oh my God. I mean, those patients, by and large, my guess is they're pre-terminal, and for them, really, it's clinical trials. I mean, in our practice, if you go to CAR T, you failed Len, POM, bortezomib, carfilzomib, daratumumab, cyclophosphamide, bendamustine. All of those are active agents that are failed. Obviously, if they have if they have 1114 and haven't received venetoclax, that certainly is an option. If we have stem cells cryopreserved, a salvage autologous transplant becomes an option. But most of those patients have to be referred for clinical trials of bifunctional drugs that don't target BCMA. I mean, you fail, again, it depends on prior therapy, but in our practice, if you progress on CAR T, which 80% will, it's basically investigational clinical trial phase 1.
This brings me to another question, though you don't prefer it, but suppose a patient has failed CAR T therapy. Can we use non-myeloablative allogeneic transplant in this patient?
Well, sure you can. I mean, the question is, does anyone know how effective it is? Obviously, when you fail CAR T therapy, you're looking at engineered autologous T cells. Now you're asking about allogeneic T cells. And of course, there are allogeneic CAR T trials, which would be different. But now you're looking at just someone else's T cells. And will that be able to recognize? And of course, sometimes, if that's all you have left, it's reasonable. Nothing really has been published that I'm aware of a series of non-myeloablative allogeneic transplant after CAR T failure. I'll bet money that it's not going to turn out spectacular.
Thank you so much. Thank you.
It's a pleasure.
Dr. Gertz, is it correct that there is a huge waiting list for CAR T and not enough patients are getting CAR T?
Oh, it's terrible here, both in the research and non-research. Remember, for non-research, we're completely dependent on the drug company to have the manufacturing facilities when we send them. And right now, they actually are victims of an employment shortage in the United States. We have employment is an issue. And, we talk about supply chain the way we talk about, oh, well, okay, supply chain, I can't get Christmas gifts for my kids, Diwali gifts for my kids. And we have a shortage, of foodstuffs. The supply chains affected our ability to re-engineer the CAR T product. So it's an enormous wait list. And I see patients, and I'm referring them, since I'm in Minnesota, to centers in Chicago, Minneapolis, Iowa City, Denver, New York, to get on their CAR T list. Even the trials are notifying us every month about how many open slots we're going to have. So the number of patients who want to get CAR T is, way, way more than the number of available. So you're completely accurate, Dr. Agarwal. At the wait list, research and non-research is silly. It's ridiculous right now.
Right, sir. Thank you so much. You made us very, very wiser. We are grateful to you. And next Saturday, we are again with you.
Yes, we'll see you then, talking about transplant.
Yeah. Okay, sir. Bye-bye.
All right, Dr. Agarwal. Thank you, and thanks to all of you. Bye-bye.
We have official vote of thanks from Mr. Ashish.
So thank you so much. And we at Zydus sincerely thank MSG and Dr. M.B. Agarwal for giving us this opportunity for supporting today's webinar. I sincerely thank Dr. Mori for his great session today, and through his session highlighting every aspect to be taken care by clinician in high-risk myeloma. A very, very insightful session, and he also answered $1 million question on myeloma, whether cure or managing myeloma as a chronic treatment. Thanks to him for patiently answering all the questions from the discussants. Thanks to all the eminent faculty for a wonderful discussion, and not to forget our respected virtual delegates who have joined us from India and across the globe. I once again thank Professor Dr. M.B. Agarwal for his untiring efforts to create such platforms to improve hematology care in our country. It was a great session today evening. Thank you, sir, and thank you, everyone. Good night for now. Take care.
Thank you, Mr. Ashish Kumar, for supporting us. Bye-bye.
Thank you, sir.